So that's the deal with the drug cards and what you'll need to end up doing. I believe this URL is still active, and it's basically his. It's a website that is goes along with the text. So there's a lot of animations and videos, and if there's something that is an update, he'll include it on the site. There's drug pronunciations, which is always a challenge. There's quizzes. There's all kind of stuff out there for you to help reinforce this. So, just definition of what we're talking about here. This is recording. And we are good to go. Study of drugs, including their origins, properties, interactions, and how they interact with, as far as how they interact with us. That's kind of what this whole process is. Has anyone taken a pharmacology class prior? I think Kathy said she did. Okay. We're going to spend far more time, obviously, on the respiratory drugs than many other pharmacology courses that are more generic in nature. We will cover some cardiovascular, some antibiotics, some other drugs, but really focusing on the drugs that we administer ourselves. So what do you think? Is aspirin a drug? It's actually one of the coolest drugs, but that's mint. Can be thought of as something.
Yes.
Definitely. Vitamins. They have a biological activity on the body. They are. Black cohosh. You ever hear that? No, it's not a hash. Cohosh. No, they don't sell it in Denver.
Yeah.
It's one of the purported treatments for hot flashes in women. But it does interact with the body, and part of the problem, especially with some of these things that are over-the-counter herbal medicine, shall we say, is they have biological effects that can often interfere with the intent of the drug that we're giving. So you have these things causing kind of counter interactions with them that can be harmful to the patient. So, where do we get drugs from? Most of the stuff that we have now is chemically synthesized, including the recombinant DNA, where they basically reconstruct from a DNA source, biologically adjust the DNA to create a drug. Some of them have their origins in various animals or plants. If you go back and actually study pharmacology in depth, a lot of the medicine men in tribal cultures were mixing various plants, animal extracts, to treat people even before they knew why it was working. Kind of interesting. And we'll go through some classic examples as we go through this. FDA, you guys all know about the Food and Drug Administration, was established, gosh, I don't even know when it was established, early 1900s. Is there primarily to regulate not only drugs. People think they primarily focus on drugs, but they also focus on any medical equipment. So if a medical manufacturer wants to introduce a new product onto the market, it's the FDA's that they have to get approval for. Now the interesting thing about the FDA is they approve drugs for a given purpose. It doesn't mean that that drug cannot be utilized for other reasons. For instance, helium. Helium is a inert gas that we use in combination with oxygen to treat patients with airway obstruction. It is not FDA approved. Okay? It's not approved for that purpose. Do we still do it? Yeah. If a physician orders it, he can order it, we can administer it. It's called off-label use. Okay? And there's lots of medications that were intended for one purpose, and they found out that it worked very good for some other purpose, and many times the manufacturer doesn't want to go back and go through the FDA process, but it's utilized for that. Okay? And we'll find that there are a lot of drugs that when the medical person was, or when the pharmaceutical company was creating it, they found out that it did something totally different and changed the entire concept. Minoxidil, which is Rogaine, was actually started out as a blood pressure medication, and they noticed during the trials it wasn't doing a really great job of controlling blood pressure, but men with male pattern baldness started getting hair back. So they said, maybe we'll change this to make it a topical solution for men with hair loss. So kind of an interesting aside as far as process of going through the testing changed the entire thing. This is a website that I actually utilize every December, because I go through and I see if all the drugs that we are currently using are still on the market. Because drugs do get dropped as time goes on. We'll talk about that as we go. But it's a great website. Usually has all of the product inserts for any medication you want. If you probably have gotten medication at some point where they had the piece of paper in there with all of that garbage that you read. That's right. But they have them for each of the drugs that we use. So if you want, it's a good thing to download and have. Drug approval can take a long time, and that's why they're so invested from a financial standpoint into it. And there's a lot of medications that never get approved over the process because they either don't work, they're not superior to something else. Any medication that is approved has to be as good, if not better, than whatever it's compared to. If it's not as good, why would we want to approve it? Why would we want to have it? Now, I'm not a big fan of the FDA. I sometimes think they wait too long to do things. I'm going to draw a blank on the name. There was a medication in the late 50s that was given to women in the early part of their first trimester. Thalidomide, thank you very much. It was given for to treat nausea, and it ended up causing birth defects. And FDA goes up, see? We took our time. Those people over in England rushed the drug to the market, and now you have babies with no arms. Okay, you did one good thing. Every time they come out with a new drug and they say it's going to save 90,000 people per year, I said, well, what about last year when you had 90,000 people that died because you didn't have the medication? So I'm not a big fan of them, but sometimes I think they wait too long. But you can see that it's a huge cost to the manufacturer. Lots of things need to be done in this process. They need to identify the chemical structure so they know what is making it up. They look at animal studies initially to verify what the toxic level is. And then it gets into various stages of drug approval. Phase 1 is where we use it on healthy volunteers to see what kind of effect it might have. Phase 2 is volunteers who have the disease. So a lot of times you'll see notices and advertisements looking for people who fit within a particular target age range maybe, and who have a specific disease that they want to try a new drug on. And then finally, phase 3 is the one that is the most important. It's the large multi-center study, where not only is it one research center that is doing the research, it's across the country, or more often across the world. So they'll have a site in Germany, a site in Sweden, a site in England, multiple sites here in the U.S. And then they apply for the drug to be approved, and the FDA will either approve it or not approve it. And then there's a follow-up. I think it's actually longer than 6 months now, but they want to follow up once the drug has been instituted, that there's not any kind of other stuff going on. Multiple sources for drug information. There is this thing, I believe it's still published, although with the internet it very well may not be. It was called the PDR. Is it still published? It's this big-ass book, and it's got basically the product inserts for every drug printed up on paper. Like, okay, whatever. But one of the nice things about it is that it's got a picture of each pill or medication, so that's kind of nice, so you know what it looks like. There is something called the USPNF, the United States Pharmacopoeia National Formulary, that basically is the listing of all the drugs that have been approved by the FDA. Now, not every drug that is approved by the FDA necessarily is approved by a given institution. So, for instance, Henry Ford Macomb may have levalbuterol on their formulary, they may not. So if a drug does not fit into the hospital's formulary, if they don't want to approve it for that specific institution, they don't have to. If a physician writes an order that he wants that drug, they'll tell him, well, we're going to substitute this drug instead. It's cost. Again, when a new drug comes on the market, as you probably know, it's the most expensive one, and any drug that it replaces or is substituted for is a whole lot cheaper. Well, the pharmacy is one of the most expensive departments within a hospital. They want to try to cut costs as much as possible, and unless something has a definitive improvement over the prior drug, they're not necessarily going to approve it. Yeah, Cass.
So would that turn into a generic? Or
Not necessarily. Let's say that. I'll give you the example of levalbuterol, which was a drug that came out as a competitive drug to albuterol, as we'll find. It had, in theory, less cardiac side effects, so that was a drug that was being used as a replacement for it. Well, a lot of hospitals initially balked at it because it was also a lot more expensive. So what they would do is they would say, well, you have albuterol, unless there's some great reason to get this on the formulary, we're not going to add it on. And it took a long time for levalbuterol to finally be adopted by most institutions. But right off the bat, a lot of them balk at it. Especially when you get into like the cancer drugs. The cost of them is unbelievable. But again, you can go ahead and check the FDA website to see what's in that. So every drug that we will cover, we'll talk about these different topics related to it. The name of the drug, and for some of the drugs, that's all you need. You'll need to know the general classification of where it fits in. It's a inhaled corticosteroid. Its generic name is budesonide. Its trade name is Pulmicort. That's all you need to know. Bitchin'. I'm happy about that. Some of them, though, we're going to get a little bit more in depth because, again, we're going to use them a little bit more often. What it's indicated for, how it works, what it actually does, any adverse reactions, or more commonly known as side effects, anything that happens that you don't want necessarily to happen, any contraindications, meaning anytime you don't want that medication to be administered, and obviously with the dosage, which will include the route that it's going to be administered in. So some of the examples, here's a chemical name. I have no idea what the hell that is. Sometimes when they're in the manufacturing process, they have a code name. Ooh, SCH-1000, dude. And then finally, it'll end up be given a generic name. This is assigned by a independent group. So an example would be ipratropium bromide would be the generic name. And that generic then becomes the official name that ends up in that U.S. Pharmacopoeia National Formulary, and that generic name is the name that is maintained even once the patent runs out. Now, most medications have a fixed length of time that the manufacturer can be the sole person to manufacture it, and this is where they recoup their investment. So, for instance, acetaminophen, when it first came out as Tylenol, I guess I'm probably too young to remember the whole Tylenol scare where people were poisoned because of some tampering issues and opened up a whole big process. But once Tylenol's patent ran out on the drug, there's generic acetaminophen, that Rite Aid makes that you can buy. It's cheaper than Tylenol, but Tylenol still has its brand name out there. It's a trade name because it has recognition. So a lot of times you'll end up seeing that. Trade name is always what is given by the manufacturer, and you can have situations where a generic drug can have 2 or more trade names. An example there, that is ipratropium bromide is better known as Atrovent HFA. Kind of one's the generic, one's the trade. An example of two or more trade names, albuterol, when it was first released, was released as Proventil and was released as Ventolin. Same exact drug, two different companies, two different countries manufactured it. Same generic, different trades. So sometimes you'll end up seeing it. We good so far? You guys are so excited, I can tell you back. So here's an example of trade name Proventil, generic name albuterol sulfate. You can see the chemical name that is there. Oh my God, sometimes they'll have chemical structures for those of you who are into organic chemistry. Not me, thank you very much. And it gives some description further that is there. Sometimes trade names can be utilized. Manufacturer will kind of choose a trade name so that it fits in with a group of drugs. So certain drugs that end in OLOL are beta blockers. Propanolol, atenolol, metoprolol. Kind of give you a hint as to what classification they kind of fit into. Neuromuscular blocking agents we'll find end in IUM. Pancuronium, vecuronium, atracurium. And some of the drugs' name kind of gives you an idea. Slowbid, what do you think that it does? It's a slow release that you take twice a day. Nasal Cort. It's a corticosteroid that you're placing into the nose. Duoneb. Well, I'm going to guess it's a nebulization medication that has two drugs in it. So sometimes you can get a little bit of a clue as far as what's going on. That's why I got the name. As far as a prescription, this is technically what needs to be present in order for it to be a valid prescription. Obviously the patient's name, the date, the drug that we're dealing with. A lot of times it can either be the generic or the trade. The dosage of the drug and concentration if necessary. How it's being administered as far as, is it oral, is it a meter dose inhaler, is it nebulization, is it a rectal suppository, whatever. The frequency as far as how often it should be given. Ideally, you'd like to have an expiration date on there too, times 4 days, so you're not doing this forever. And sometimes it'll have additional instructions that need to be monitored, peak flow before and after therapy, measuring tidal volume, such stuff like that. And then a signature. So this is just some examples. I'm not going to bore you with it. You get the idea. Abbreviations are something that really the joint has kind of poo-pooed, wanting to get away from abbreviations, and you can imagine why. You guys have all you guys have probably all seen physicians' handwriting. You know that it's not good. Now let's add abbreviations to that. Oh my, it gets awful ugly. Good news is that more and more we're seeing things with electronic medical records that it's a whole lot easier and a whole lot clearer, and we're not having to deal with handwritten orders. They're basically entering them directly into the EMR. And there is, I believe, a handout of certain things that we don't want you to use. Some of the more common ones we end up seeing: BID twice a day, TID 3 times a day, STAT, you know what that means. Some of them have been eliminated because of confusion. So QOD, every other day, write it out. Every other day. Makes more sense. QD was daily. And even the numerical ones should be pretty obvious in the process. Some other abbreviations: normal saline, C with a line over it is with, S with a line over it without. Did Mary go through these? No? You should know these too. You don't need to know these because they're gone, but you do need to know these. The others 4, yeah. Before meals, after meals. Milliliters you're familiar with. QT or GTT or QTT as it's written is also as a drop. QS, quantity sufficient. What that means is I want to have 2.5 milligrams of albuterol, quantity sufficient, normal saline. Meaning I'm going to go ahead and have 2.5 milligrams of albuterol, and we'll get into how many milliliters that works out. It's a 0.5% solution. You can do the universal drug equation to come up with it, half a milliliter. And you're going to mix it with enough normal saline so that the treatment lasts for an appropriate amount of time. So the quantity sufficient is really kind of left up to us as far as how much that is. PO by mouth, or better known as orally, some more that you'll need to know. And most of these will end up encountering meter dose inhaler, IPVB. She didn't go through IPV yet, did she? You guys didn't cover that last semester? Small particle aerosol generator is called a SPAG, not utilized as much as it once was, but it's still used as some for specific uses. RX is what is known as a prescription, literally meaning recipe or take thou. IM, IV, DPI, those are all pretty straightforward. NPO, OTC, MOUSE. BS is a real problem because if you look in nursing notes, they're going to have BS also as bowel sounds. So kind of it's a bad abbreviation because it can mean multiple things, but in our world, it's breath sounds. PF, PEF, PEFR, all P meaning peak expire flow rate, peak flow. And we're going to use this as one of our measurements that we'll do frequently. Some other ones that were eliminated you can ignore. They were discontinued. This is kind of what everybody says, the 6 rights: the right drug, the right dose, the right patient, the right time, the right route, the right documentation. Okay. Okay. Well, there's 6. There's actually 7 if you want to have the right to refuse being there also, which is again a patient's right that they have is to.
Well, we don't have that one on.
Okay, well, you can add it on then, can't you? I'm not going to ask you what the 6 rights are, so don't worry about it.
Blast right.
Okay, so let's talk about how these things are administered. Okay, and it really is broken down into a couple different aspects as far as it being absorbed into the bloodstream, the bottom there. If it's an oral medication, it's absorbed into the bloodstream. It goes ahead then and through the digestive tract, goes to the liver, and sometimes to the target organ. So various types of enteral meaning that it's going through the enteric system, going through the GI system in some fashion. Oral is obviously one of the most common ways that we take medication in, PO. It can be a tablet, it can be a capsule. You know what the difference between those two are. Capsule having a degradable outer shell into which the medication is placed. It can be a powder, it can be a solution, an elixir, a syrup, an emulsion, or a gel. Those are all oral, all stuff we put in our mouth and swallow, basic of it. You can also have as a enteral route a sublingual where it's being absorbed into the body through underneath the tongue. Nasogastric, obviously through the nose and into the gastric system. And along with this also in this enteral route is anything that's given rectally. And because these are all enteral, they're all subject to what we're going to call the first pass effect, meaning that it has to be absorbed. It has to be absorbed by the GI tract in order to get into the bloodstream in the process. Anytime we bypass that tract, anytime we bypass the alimentary tract, we're going to call those parenteral. Because it's being administered directly into the body, not going through the GI tract, there's no problem with a first pass effect. Yeah?
How are sublinguals in the GI tract?
They just classify it in there because it's in the mouth. It seems like an odd one, but that's how it does have to get into the bloodstream in that process, but it's through part of the alimentary canal. I know it's kind of an oddball one. personally, I don't know if I'd put it there, but they do. But again, it's a big vascular area. I don't want to go there. Good news is there's nothing we administer that is rectally. But it's some of the parenteral routes that you have. Intradermal into the skin. Subcutaneous below the layer of skin. So insulin, for instance, would be a good subcutaneous drug. Intramuscular. Any of your vaccinations that you'll end up having are in that category. Intravenous, meaning it's going directly into a venous system, usually through an indwelling catheter that is there, an IV catheter. Intraarterial, I don't see that happening very often at all, but in theory you can end up putting stuff into the artery. Intraspinal, no thank you very much, but into the spinal cavity, a lot of anesthetic agents are obviously done in that fashion. And one of my favorites, intraosseous. Usually done into the medial aspect of the tibia, also into the ball of the humerus, or in theory into the sternum itself. And we'll find that in cardiac arrest situations where patients are obviously in an arrested situation with no blood pressure or pulse, it's hard to find IV access at times, and the preferred access is the antecubital vein. If somebody's profoundly hypotensive, though, or has lost a lot of blood, that's a hard vein to find. So the other option, because you got nothing else to go on, is to go intraosseous. And there's actually a hand drill or a drill that drills a needle through the bone into the marrow, and a catheter, and the medication then can be infused directly into the marrow. And amazingly, it's a very quick route to access. It's a route through which you can run pretty much any medication you wish, and a route through which, in the short term at least, I forgot what I was going to say. It's very beneficial. I just taught ACLS over the weekend, Advanced Cardiac Life Support, and we talked about the intraosseous site. And when I started teaching it, they brought the sales guy in to demonstrate how to use it. It's like a little drill. It's got a needle on the end. You just advance it into the bone, and when you hit the marrow, you feel a pop, and literally, that's stop. You don't have to go any further because you want to go through the bone in the process. But the sales guy was talking about how when he was going through training, they had to do it on each other.
What?
And I said, "Oh, really?" I said, on a scale of 1 to 10, what was the pain? And he said it was about a 6 or a 7. But it wasn't the drilling; it was actually the infusion that was the painful part, the pressure part, which I just thought, "Oh my." Choose a new career at that point, Yes, Dana.
What does the first pass effect mean again?
First pass effect means it has to go through the bloodstream.
Okay.
It has to be absorbed. Let me rephrase that. It has to be absorbed in the GI tract into the bloodstream. So it's not something where it's going directly into the bloodstream. Okay. Parenteral. Those are all examples of parenteral routes. So we have enteral, parenteral, and then there's some other ones that fall in. Topical would be things like transdermal creams and gels. Patches would be examples of topical administration. That Rogaine is a topical administration. And then there's our group that we have as far as inhalational. And we will use things like small volume nebulizers, large volume nebulizers. More commonly, we're starting to see drugs being released as only meter dose and dry powder, because they're a whole lot easier to work with, as we'll find. So here's some examples of a small volume nebulizer, a large volume nebulizer, and that SPAG, small particle aerosol generator.
Are these illustrations out of the...
These are out of Egan, actually. Yep. Meter dose inhaler, dry powder inhaler, and there's a ton of these that we'll end up encountering as we go. So this is out of Colbert, your text, Kind of has a summary of all the different routes, their major points, as far as why they're preferable, and some examples of each of them that you might end up seeing. Okay. Sometimes you have a situation where you want to nebulize something on a continuous basis, where we would use either a large volume nebulizer. And this is an example of where you end up having a situation where I want to deliver the therapy instead of over 15 minutes, I want to deliver it over 4 hours. So you don't have a peak and then it wearing off. It hits the peak and it stays there for a prolonged period of time. We'll see that a lot with patients that are in severe asthmatic attacks. We'll do continuous therapy on them. And here they've actually adapted the nebulizer. Thank you very much for those showers. They've adopted a non-rebreathing mask to have the nebulizer so they can continue to administer high quantities of oxygen while they're doing the therapy. So they're getting the best of both worlds and the patient's not sacrificing having to come off the oxygen to take the treatment. So why are we so concerned about aerosolized medications? Well, for one, it's a smaller dose that we end up using than typically doing it as a parenteral or an enteral route, because it doesn't have to be absorbed or brought through the vascular system. It's going directly to the targeted system, in this case, the respiratory system. Because of that, there's less side effects. Giving a medication as a syrup means it's got to be absorbed into the GI tract, but it means it also goes everywhere else. Giving that same medication as an inhalant is a much better option. Quicker onset, usually a little bit more safe in the process, and definitely painless. I mean, you're breathing medication in, that shouldn't be involved in any pain, I would think of. And certainly can be a whole lot more convenient in the case of a meter dose inhaler, which can fit inside, a school bag or a purse or a pocket or something. And more often than not, we can train them to administer the medications themselves. Some of the groups of medications that we'll cover, we'll spend a lot of time talking about bronchodilators, because that's our primary one, both parasympatholytic as well as sympathomimetics. Mucolytics, drugs that alter the structure of the mucus and allow for improved mucokinesis. Inhaled corticosteroids and systemic steroids, we'll talk about them. Non-steroidal anti-inflammatories like mast cell stabilizers and leukotriene inhibitors. And then your antibiotics, your anti-infective agents, anti-tuberculin, anti-fungal, all the rest of it. We're also involved often with nicotine replacement therapy. If you get a patient who's a smoker, comes in the hospital, they can't smoke inside the hospital, what a great time to begin the process of getting them to stop smoking. Now, yes, they go outside in a wonderful hospital gown and stand out in the freezing cold with their butt showing. It's like, really, dude? But if there was a role for a respiratory therapist, this is a perfect role as a counselor or an individual who's going to talk about smoking cessation at the same time implement nicotine replacement therapy. Typically patches, although it can also be the gum or the inhalant. Some topical anesthetics, don't see lidocaine utilized that often as a topical for blood gas purposes. I've had patients who insisted they get a small wheel of lidocaine prior to the puncture, and it's like, dude, I'm poking you twice. Just whatever. But it's there. And various, obviously, inhaled gases are also classified as, obviously, drugs in the process. One of the things that will that is fascinating is that morphine is typically thought of as a medication which is administered intravenously for sedation purposes. It also can be inhaled for dyspnea. It's actually a very, very good drug for that purpose. Our license does allow us to handle controlled substances like morphine and to be able to administer them in the inhaled form. A lot of pharmacies, it's more of a hospital policy issue than it is a licensing issue. But there's nothing within our license that prohibits us from not handling that medication.